Good afternoon to everybody. I am Dr. Kiran from Department of Vascular Surgery, CMC Vellore. I am working as an assistant professor. So we will be discussing about peripheral arterial occlusive disease in diabetic foot. So we will be discussing about association of diabetic foot ulcer and peripheral arterial occlusive diseases, importance of pulse, importance of ABPI, toe pressure, the different modalities of imaging in vascular disease, different aspects of management, which include medical management and surgical management, and different case studies. Coming to the incidence, around 50% of patients develop diabetic foot ulcer during their lifetime. 85% of non-traumatic lower limb amputation is preceded with foot ulcer, especially in diabetes. The need for amputation is more compared to the general population, around 5 to 10 times higher in diabetes patients. When coming to the magnitude of the diabetes and diabetic foot ulcer, so as we all know, India is becoming diabetic capital. Around 69 million patients is there in India with the diabetes. Prevalence of diabetes is 9.3%. Annual incidence of diabetic foot ulcer is ranging from 1 to 4%. In diabetic patients, patients are 2 times risk for the amputation compared to the non-diabetic patients. Major amputations around 10 to 30 times, whereas 8 out of the 10 non-traumatic amputation is secondary to diabetes. Coming to the association of diabetic foot ulcer and peripheral arterial occlusive disease. So this is the nutshell of the different pathological process which is happening in the diabetic foot ulcer. So as we discussed just now, so there will be underlying neuropathy, there will be trauma, and underlying vascular disease. So coming to the neuropathy, it can be motor, sensory, and autonomic neuropathy. Motor neuropathy will cause the weakness and atrophy of the intrinsic muscle, especially in the lower limb, and cause the deformity, and it will cause the abnormal stress. So because of this deformities, the pressure point will be changed. So as we all know, pressure is equal to force by area. So as the area decreases, secondary to this deformities, there will be more pressure on those particular areas. So then that particular area is not resistant to the increased pressure. So that will cause the callus formation. And also come to the sensory neuropathy, there will be loss of protective sensation, and the proprioception loss will be there. The autonomic neuropathy also will be there underlying. So which is present as anhidrosis, dry skin, fissuring, decreased sympathetic tone. So secondary to the decreased sympathetic tone, there will be decreased blood supply, and autoregulation to the lower limb also will be affected. So all this will cause osteoarthropathy. And if there is a trauma to those patients who has already neuropathy and underlying vascular disease, then it will cause for progression of ulcer, and they may end up in amputation. Then underlying vascular disease, there will be microvascular and macrovascular disease. Usually macrovascular disease will be affecting the major blood vessels, including subclavian, arch of aorta, aortic branches, external iliac, femoral, and distal vessels also can be affected. So which will cause the non-healing ulcer, especially in diabetic patients. And especially in diabetes, healing process also is impaired, secondary to advanced glycation products, which will decrease the permeation of the blood circulation to the ulcer, and also it will increase the biofilm, which is secondary to the chronic infestation with the commensals. Coming to the natural history. So as we discussed in nutshell, diabetes patients will have neuropathy. Secondary to that, there will be deformities. It will cause the ulceration, underlying infection. If there is a macrovascular or microvascular disturbance, then patients will have ischemia. So if we can't treat appropriate, then patients will end up in limb loss. Then coming to the importance of the pulses. So why we have to check the pulse? So main thing is we should know about the vascularity of the affected limb. Especially if there is a patient is diabetic, there is a high chance for accelerated atherosclerosis and arterial occlusion. So which will define the segment of the vessels which is included. So usually we will divide the arterial occlusive disease especially in diabetes in aorta iliac segment, femoropopliteal segment, and which is involving the tibial vessels. So above the inguinal ligament, above the popliteal ligament, and below popliteal artery and below the popliteal artery. So it will help us to plan the appropriate treatment. So what all pulses has to be checked? Basically, aortic pulse, external iliac artery pulse, internal iliac and common iliac artery pulse, we can't palpate, but those are very important. Palpable pulses are femoral, popliteal, posterior tibial, dorsalis pedis, and anterior tibial artery pulses. So as we all know, femoral pulse will be examined in supine position in midinguinal point. Posterior tibial pulse will be checked in medial aspect, posterior to the medial malleolus, in the junction between the line joining medial malleolus and the heel of the calcaneal tip, the junction between medial two-third and lateral, medial one-third and lateral two-third, dorsalis pedis, and popliteal pulse. Popliteal pulse will be difficult to elicit in obese patient, still it's worth checking. Coming to ABPA, if the pulse is not palpable and if the patient is having diabetic ulcer, then ABPA is very crucial. So as we all know, ABPA is a method for disease classification, and also it has its own prognostic importance. So basically, we will measure both in angle and brachial pressure. Angle pressure will be measured at the level of posterior tibial artery or dorsalis pedis artery below the angle, in which we will be applying the cuff just proximal to the angle joint. Whereas brachial pressure will be measured in radial artery or ulnar artery, in which we will be applying the tourniquet at the level of brachial artery. So suppose if the right side, the ABPA right sided lower limb ABPA we have to measure, then right sided angle pressure will be divided by highest of the upper limb pressure. So this is the method for checking ABPA toe pressure. This is the cuff which is applied, which is shown in blue in color, and probe is, the handheld Doppler is kept in the posterior tibial artery territory. Then coming to the different grading of decreased ABPA. So it is normally 1.1 plus or minus 0.1, which is accepted as a normal value. Intermittent claudication patients will have a ABPA value of 0.6 plus or minus 0.2. Ischemic respiratory patients will have 0.32 plus or minus 0.1. And impending tissue necrosis patients will have 0 to 0.1. ABPA is unreliable in diabetic and renal patients. So this comes the importance in our topic discussion. The reason for ABPA is unreliable in diabetic patients is because of in diabetes it will increase the accelerated it will cause the accelerated atherosclerosis. Along with that, there will be arteriosclerosis also. There will be increased calcium deposit on the vessel wall. So it will affect the pressure reading. So ABPA will be wrongly, it will be elevated. It will be more than 1.5. Some patients can reach up to 3. So the same similar scenario we can see in patients with renal failure also. So in those patients, ABPA is not reliable. So what we can do next? So then comes the importance of toe pressure. Toe pressure is, we are measuring the small vessels which is applying near the toes. So which one won't be affected with the diabetes. So there won't be much calcification of the blue vessels which is supplying the toe. Interdigital arteries are not calcified like the proximal vessels. So toe pressure is more reliable in diabetic patient than ABPA. So coming to the different gradients. So if there is a diabetic patient and the toe pressure is more than 60 millimeter of mercury, there is a good chance for healing, and decreasing poor chance of healing if it is less than 40 millimeter of mercury. Then coming to the imaging of the different vascular disease. So first basic test is arterial Doppler. So we can do on bedside or we can get it from radiology department. There are different types of Doppler machines are available on table mount, and we can get the portable one also. The most important advantage is non-invasive, but the main disadvantage is an operator dependent. So one person, one radiologist or one clinician will be documenting one pulse or one finding, which may not be reproduced with the other scenario. But if depending upon the radiologist or clinician's expertise, it will become more reliable. It can be and it cost effective also. Coming to the next angiogram. So usually in the arterial disease and diabetic patients, if there is a femoral pulse and popliteal pulse palpable, so we don't have to get for CT angio. It varies in each clinical scenario. So then there are different types of CT angio available. So early times it was helical CT. So there was only single detector was there. So we don't have that much accuracy and detailing of the anatomy of the blood vessels which is affected. Nowadays we have MD-CT, multi-detector CT. There are up to 320 detectors are available, which will rotate across the patients in circular motion, will produce the good pictures of the blood vessels. So coming to the specificity and sensitivity of the CT angiogram for the aorta, iliac and fempoid disease, sensitivity is around 93% and specificity is around 92.7%. For the infrapopliteal segments, it is decreased to 91.6 and positive predictive value of 78%. Coming to the advantages of the CT angiogram, it's less invasive, less expensive, it's very easy to perform, and it's compared to DSA, which is a digital subtraction angiogram. Its radiation is 4 times less, and it's a very good modality for the aorta, iliac, and femoral segments. And we can see the calcification. The calcification, as we discussed already, it's very prominent in diabetic patients. More calcification means diabetes is not controlled. That is one. Second thing is the procedure complication, etc. That also will be depending upon the amount of calcium which is present on the blood vessels. Coming to the disadvantage, it's an invasive procedure. We are using contrast medium. Some patients can develop the contrast allergy, and it will be difficult for the CKD patients or impending CKD patients, especially in diabetes. Contrast will cause the contrast will have nephrotoxicity, which will push the patients to the CKD stage also. As we discussed, radiation is a side effect. Metallic implants and post-traumatic patients with X-fix, so those patients will be difficult to interpret the vascular anatomy. Coming to the MRI angiogram, so there are 2 types of MRI angiogram is available. One is contrast MRI and non-contrast enhanced MRI. Usually we will use selenium in a contrast MRI. Main limitation of the contrast MRI is nephrogenic systemic fibrosis. As we discussed in CT angiogram, it will cause iodinated contrast will cause nephrotoxicity. The similar scenario in MRI, it can cause diffuse fibrosis. So we can, it's a good modality for tibial vessels, for the calcification and stent artifacts. All this will be picked up with the MRI. Sensitivity is around 93% and specificity for 94% for and femoral segments. Coming to the non-contrast MRI angiogram, especially in those patients, CKD patients not on dialysis, CT angiogram and contrast enhanced MRI should be avoided because it will push those patients to the proper CKD and patients will become dialysis dependent. So there are different protocols are available for non-contrast MRI angiogram, which will include 2-dimensional time of flight, electrocardiogram, path-spin echo, balanced steady state free position, and QASS protocol. So that's MRI. So MRI depends. The basic mechanism is it's in the high magnetic field, electromagnetic field. So water molecule in the body, it will act as a dipole and will align according to the nature of the tissue which is present. So there is no radiation we are using, only electromagnetic field and magnetic field we are using in this. So it's non-invasive. It's ideal for calcified below tibial vessels. And the non-contrast MRI is accepted, especially for those patients who is going in the borderline of CKD. Coming to the disadvantage, it's a prolonged duration, and the patients will have claustrophobia. and is not accepted for those patients with metallic implant. Then coming to digital subtraction angiography, there is a two-dimensional image of vasculature will be elicited with injecting uh, by iodinated contrast. Access will be through the blood vessel. We will be puncturing the blood vessel under ultrasound guidance. We will keep the sheath inside, and through that sheath we will demonstrate. We will be injecting the iodinated contrast, which will give the dynamic vasculature of the patient in real time. So disadvantage and advantages of CT and MRI we already discussed. So there are different contrast materials we are using for DSA. Ionic and high osmolar contrast will cause nephrotoxicity, and patients will have more chance for acute kidney injury or contrast-induced injury. Non-ionic, low osmolar, iso-osmolar, so which is replaced already the high osmolar components nowadays, which has decreased chance for contrast-associated nephropathy, because it will decrease the diffusion into the peritubular capillaries, and it will decrease the tubular necrosis of the kidneys. So that's the reason why these products will decrease the contrast-associated nephropathy. In those patients who has limited renal reserve, or those patients with decreased EGFR, so other option is carbon dioxide angiography, especially the EGFR of less than 30 ml per minute per 1.7 millimeter of square body. Usually we will use the carbon dioxide. And those patients with hypersensitivity to contrast, which is iodinated, those patients also will be helped with CO2 angiography. So unlikely the patients will have a hypersensitivity and a nephrotoxicity with the CO2. It will dissolve within 50 to 20 seconds. It usually will be excreted by the lung. And the main complication with the CO2 angiogram is embolism. So it will usually is not recommended for the vasculature which is above the diaphragm. Diagnostic accuracy is also good, but it's less compared to the iodinated contrast. So this is the various disadvantages and advantages of the CO2 angiogram. Then coming to the one of the latest imaging is IVUS, intravascular ultrasound. So all the modalities which we have discussed till now, whether it is CT, angio, and DSA, it won't give the intraluminal picture. So it won't be giving any view of the blood vessel from the interior. There will be artifacts, different artifacts will be there. So in IVUS, so we will be sending an ultrasound probe, the same probe which we are using for the normal ultrasound. There will be a small probe which will be around 2 to 3 mm in diameter, will be sent to the blood vessel inside. So we can demonstrate the intraluminal pathologies, especially calcification, plaque, atherosclerosis, stenosis, etc. So compared to the other modalities, we are seeing the blood vessel from inside, not from outside. So advantages are better quantification severity of stenosis than DSA, and it also will help to make a more precise decision regarding whether usually we will be doing angioplasty. If plasty is failing, we will be placing stent. So whether it's a plasty is successful or a stent sizing, etc. So with DSA and the other modality which we discussed, CT and MRI, so there will be some disparities. So but IVUS will give a more precise details about the stenotic lesion and the post angioplasty pictures. Disadvantage is it will be add to the cost, and it will require more technical expertise. Coming to the medical management of diabetic foot ulcer, requiring a bed rest, myelitis, we have to send the bone culture from the curettage, which will give the proper picture of the associated organism. Antibiotic is only it's required when it is indicated, because if the patient is not having any features of sepsis, or if there is no cellulitis, there is no point in giving antibiotic, because already there is a blood supply is diminished. Because already there is a blood supply is decreased, and the perfusion to the wound also will be diminished. And coming to next modalities, as we discussed, clinical examination and examination of body. And if it's indicated, patient should undergo for vascular imaging. And depending upon the imaging, we have to plan for revascularization. Then the main thing is we should treat the predisposing factor, especially if there is uncontrolled diabetes. We should start insulin. If there is a sepsis, definitely, because otherwise patient can go for hypoglycemia and associated morbidity. Patient should convince for stop smoking. Food care, as we discussed already, crucial. So all this will decrease the progression of the diabetes. Then next target should be, we should increase the blood flow. So exercise will have positive feedback to the increased vascularity. So, but the main problem is secondary to the diabetic neuropathy and all the pathologies we discussed. The role of exercise in a DF, diabetic foot ulcer, and associated POD is less. Then coming to the best medical management, drugs which we are using is antiplatelets, aspirin, pentoxifylline, and silastazole. All these are antiplatelets. It has a different mechanism of action on platelets. Silastazole is the only proven drug which is shown in different case studies. It will increase the claudication distance. Then patients will have severe pain. One is secondary to the infection or tissue loss, and the second one is secondary to the decreased blood supply. So we can give analgesics in form of paracetamol, NSAIDs. Always we should check the renal status before starting NSAIDs for the patient, especially if there is a diabetes, and those patients are highly prone for kidney injuries. Then if he can't break the pain cycle, then patient will benefit with the epidural analgesics. As we discussed already, antibiotics are needed only in case of indicated patient. And if there is any underlying abscess or necrotizing soft tissue infection, we have to debride or we have to drain that abscess. Then coming to the surgical management of peripheral arterial occlusive disease and diabetic foot ulcer. As we discussed, sepsis control is crucial. If the patient has necrotizing soft tissue infection, or if there is any abscess, that has to be treated first. Initially, we should achieve the sepsis control, but debridement or drainage or amputation should be minimal. We should remove the sepsis, but we should not go beyond the. We don't have to get exact sepsis, we won't be able to achieve the debride to the healthy tissue as compared to the other tissue. Then coming to the indications of amputation, acute life-threatening, rapidly progressing infection, those patients with sepsis, and we can't salvage the foot, patient will require amputation. Chronic ulceration or infection that persists despite the treatment, and if there is a gangrene, severe uncontrolled deformity or non-viable limb, these are the main indications for amputation. Then coming to the management algorithm for diabetic foot, as we discussed, if there is a sepsis, we have to get the sepsis control first. We have to assess the perfusion and degree of neuropathy and the mechanical abnormalities after getting the sepsis control. If there is a dry gangrene or osteomyelitis, again, we can assess the vascularity before any surgical intervention. So there are different types of modalities are available to increase the blood supply. Either it's endovascular, can be or open surgery. Endovascular will include balloon angioplasty plus or minus stenting. Surgeries will include anatomical or extra anatomical bypass. So the crucial points are should check and document pulses for all the patients, especially in the first visit. Angle brachial pressure index. If it is required, patient will require arterial duplex, CT angiogram as we discussed in selected patients. And in case if it's indicated, antibiotics, and the offloading has crucial role. So when we have to refer the patients to the vascular surgeon, if the patient has not able to sleep, if he has a disabling claudication, has a growth sepsis foot or limb, pulses are not palpable, the gangrene, all these conditions is a clear indication to refer to the vascular surgeon. So main is we should not debride any wound if the pulse is not palpable, because we will be making an injury. So main pathology behind the diabetic foot ulcer is if we debride, it will start going proximally. If there is an ischemia, if we are amputated, if there is no adequate blood supply to the affected area, it will go proximally. So ischemia will go proximally. So we ended up in amputating the higher level. So it should not, we should not debride unnecessarily if there is no pulse. Then we'll be discussing about different case scenarios for better understand. So now first patient, he is a 64-year-old male gentleman. He is diabetic for past 7 years. He is a smoker also with the pack year of 31. He has rest pain for past 1 month. On examination, so there is a ulcer, fourth web space. That's lower limb pulses are absent. ABP on the right side is 0.45 and left side is 0.3. Top pressure is both sides 0. So anybody would like to give approach the patient? Yeah, CT angio. Yes, correct. So as we discussed, no pulses are good on both sides. So patient will benefit with the CT angio, provided patient's creatinine is normal. So that is also a thing which has to keep in mind. So this is the CT angio picture. So which is showing, so both kidneys are visualized in the picture.
So in the CT angio, it's we can see both kidneys are visualized and aorta is occluded just below the renals, and the reformation is in the common femoral artery, which is shown with the pointer. So patient has aorta-iliac occlusive disease. Even though the picture is showing only small ulcer on the fourth web space, underlying pathology is crucial. So if you started debriding or if you started removing the toe, patient will end up in even with above knee amputation or hip disarticulation. So pulse examination and imaging is very crucial. So after assessing the patient risk, patient underwent aorta bifemoral bypass. So in which we will reconstruct the aortic bifurcation, and it will be anastomosed to the both external iliac artery. So this is a picture representation of aorta iliac bypass. So post-operatively, so as we discussed, ABP has on prognostic and importance. So it's from 0.6, it's increased to right to increase to 1, and in the left side it is from 0.23 it is increased to 0.6, and wound healed very well. Then coming to the next patient, is a 55-year-old gentleman, is diabetic for past 6 years, and so pack years of 27 years. Patient has rest pain and ulcer on the right forefoot, as we can see in the picture. ABPA was 0.24 on the right side and 1.03 on the left side. Top pressure on both sides, it's 0. Any input, how you will approach? So which is showing the aorta iliac occlusion on the right side. So patient is underwent fem-fem crossover. So usually we will plan for aorta uniform bypass. The patient has risk for open procedure. open laparotomy, etc. So one of the other alternative method is fem-fem crossover. So left side left-sided external iliac artery and distal pulses was normal, and so we will take the inflow from the left-sided external iliac artery and we'll give it to the right external iliac artery. So ABPI is improved from 0.2 to 1.07. Then coming to next patient, 60-year-old male patient, diabetic, hypertensive, smoker. Patient has ulcer on the right foot on plantar aspect. Right femoral pulse is palpable, distal pulses are absent. ABPI as shown, it's low. Top pressure is also on the right side, it's 0, and left side is 65. So what can be done in this patient? Any input? Again, we have to see for an underlying pathology, which vascular segment is included. So it is a FEMPOP segment. So this is a CT angio pictures. So right side is affected. So as been shown in the recon image. So there is occlusion of the right-sided superficial femoral artery. So this is the bypass procedure. So you can see in this picture, the proximal inflow, we will take it from popliteal distal SFA or P1 segment, proximal popliteal artery. And outflow is will anastomose to the distal popliteal artery. So we are bypassing the disease segment. So we'll increase the blood flow to the affected area where there is a tissue loss. Post-op course was uneventful, and ABPI is also it's improved. This is the fourth case. It's a 64-year-old gentleman, diabetic, hypertensive, and presented with a left grade 2 gangrene. So outside, he was treated with a partial amputation. He came with a severe rest pain, discharging amputated stem. This for past 6 months. Again, we will do the imaging. After imaging, this is on-table angio picture, which is showing the near total occlusion of the left-sided external common iliac artery. So this is common iliac artery dividing into right-sided internal and external iliac artery. Left-sided internal iliac artery is occluded in this picture. So as we discussed already, there is endovascular option also. So patient has undergone a balloon angioplasty of the affected segment. So after the balloon angioplasty, we can see when we are comparing. So in this picture, there is a near total occlusion of the common iliac artery. So post angioplasty, there is a good opacification and a good contrast crossing over the lesion. Coming to the fifth patient, he's 73-year-old gentleman. He's diabetic, hypertensive, smoker. For him, femoral pulse and popliteal pulse are palpable. Distal pulses were not palpable. And he has a significant rest pain. So again, so it's a infrapopliteal disease. So this is the DSA picture of the patient. So in which you can see usually superficial femoral artery will become popliteal artery. Behind the knee, it will be P2 segment. Below that, it will be P3 segment. After the P3 segment, popliteal artery will be divided into 3 different arteries: anterior tibial artery, peroneal artery, and posterior tibial artery. I'm showing with the cursor here. Peroneal artery is occluded after the origin. So anterior tibial artery and posterior tibial artery is the main distal outflow to the leg. So this is the anterior tibial artery which is crossing the angle. So posterior tibial artery, as you can see here, it's occluded in the junction between proximal third and the distal 2/3 of the leg. So there is no blood supply, there is no inline flow through the posterior tibial artery across the angle. So we have done the angioplasty, balloon angioplasty we had done. So we had dilated the blood vessel with the adequate diameter balloons. So we will check the angioplasty success. So we will be doing the check angiogram. So you can see here, the non-visualized posterior tibial artery is opacified with the contrast. Then patient become better and wound was healed. Then coming to the prevention of the peripheral arterial occlusive disease and diabetic foot ulcer, we should give more importance for the foot hygiene and early detection of the underlying disease. Regular foot examination, debridement of callosity and ingrown toenails, which we discussed already, offloading the pressure points, and adequate sugar control. And the most important thing is, if the patient is a smoker, we should stop smoking. Patient should stop smoking. Coming to the offloading, as we discussed already, offloading has a very crucial role in diabetic foot ulcer, because underlying pathology is not only vascular compromise. There will be autonomic neuropathy, which will cause neuropathic comorbid associated changes will cause different deformities, which will increase the pressure on the different pressure areas, will cause the ulceration. So coming to the take home messages, diabetic foot triad is because of underlying peripheral neuropathy, peripheral vascular disease, and trivial trauma. We should focus on prevention of diabetic foot ulcer, because if there is any ulcer which is formed in, especially in those patients who has an under control diabetes and underlying peripheral arterial occlusive disease, it will be difficult to treat. So the prevention is always better than cure. And always check the pulse for all the patients, especially if the patient is diabetic. Always feel the pedal pulse before taking your knife. No pulse, refer to the vascular surgeon immediately. If there is any rest pain associated with ulcer, refer to the vascular surgeon. Thank you.